So very good afternoon everyone. Today I'll be talking about the ocular manifestations in rare case of congenital erythropoietic porphyria. As you know, these porphyrias, they are a group of rare inherited disorders, extremely rare to the prevalence of less than 1 in 10 lakh of the pediatric population. They have autosomal recessive inheritance, and till now, all over the world, only about 280 clinical cases have been documented till now, and mainly from the Western countries. In this disease, the clinical symptoms, they are caused by a homozygous defect of the enzyme uroporphyrinogen, which leads to the accumulation of biologically inactive porphyrins, mainly in bones, erythrocytes, skin, and teeth. As a result, due to the accumulation of excessive amount of these porphyrins, they induce phototoxic oxygen type of dependent damage in these tissues, leading to severe inflammation and followed by subsequent ulceration and scarring of all the light exposed skin areas. As a result, there occurs severe mutilation of hand, fingers, face, especially nose, ear, lips, and eyelids. Till date, only curative treatment, if done timely, is allogenic stem cell transplantation, and the only preventive measure is absolute 100% avoidance of sunlight. So I'm presenting a case of a 33-year-old male who presented to our department with the symptom of severe pain and redness in both eyes since 2 weeks, also associated with the foreign body sensation, burning, and dryness. Visual acuity, it was good, 6/9, and on examination, ocular examination, the right eye showed approximately 8 into 4 mm area of scleral melt, which was a recurrent scleral melt. Already he has this episode of scleral melt, for which scleral patch graft was done a year back. And in the right eye also, there was a 4 into 4 mm area approximately of scleral melt temporal to limbus with conjunctival congestion. On physical examination, there were hypertrichosis, hyperpigmented skin lesions, along with mutilation of ear, nose, and fingers. On slit lamp examination, tear film breakup time was less than 3 seconds, and Schirmer's test was severe dry eye, right eye less than 3 mm, left eye less than 5 mm. As we know, the clinical feature of this disease, it varies with the age of onset. If it's in vitro, it may present as non-immune hydrops fetalis. Postnatally, patient experience severe photosensitivity, while adults, they may suffer from severe skin lesions. So, we'll be talking about mainly the ocular complication, as I also saw this case for the first time, and I searched the review of literature, and it was seen that ocular complications, they are mainly nodular scleritis. It may be necrotizing type with inflammation or scleromalacia perforans. And these necrotizing scleritis and scleromalacia perforans, they are the most commonly reported ocular complication. The exact mechanism of this pathology is not known. The study by Takamura et al., they have revealed there were levels of porphyrins in the teardrops of these patients, which may be the precursors. And the sunlight, it triggers inflammation by activating these porphyrins. Thus, a combination of these accumulated toxic metabolites, along with the increased porphyrin, they may be exposing the sclera to necrosis and melting. Thus, eye is particularly susceptible to the photo damage. If it is in the cornea, it may also lead to corneal ulcer, subsequent scarring, ultimately resulting into blindness. Others ocular complication may be seborrheic blepharitis, keratoconjunctivitis, sclerokeratitis, cicatricial ectropion. And the photomutilation of eye can destroy the eyelids, which further exacerbates the ocular damage. So our case, it exhibited a scleral melt, which indicates long-term UV damage. So the management, it includes a multidisciplinary team approach. The curative is the bone marrow transplantation. The other, what we can do is, we have to focus upon patient about the rigorous avoidance of sun and light exposure, and advise them to use sunscreens, okay, but they are not the substitute for strict light avoidance. And protection of eyes with wraparound sunglasses is must. If these ocular complications are seen, they should be addressed aggressively. Corrective eyelid surgery, use of steroids, both topical and systemic, to control the inflammation, and when needed, scleral patch graft, that is mandatory. So, and along with the systemic management of the blood transfusion, splenectomy as and required by the hematologist. So I want to conclude that it highlights the importance of awareness about the ocular complication which may occur in these cases, as it is a rare disorder. So the treating physician should also be aware of the ocular complications so that timely reference can help in the accurate diagnosis and prompt treatment of the patient. Thank